Hello everyone and welcome to the Bayesian Musings podcast. I'm your host Vishnu. Today's episode is, disclaimer, this was recorded in 2020 and was the first full episode I ever did. So many thanks to Kate Collins for her time and willingness to do this. I think the audio quality might be a bit rubbish, and I certainly learned a lot from the awful experience of listening to myself. So this will be an ongoing learning curve for me, so please bear with me on my journey to learning how to be an adequate podcaster and interviewer. So back to the episode. Today's guest is Dr. Kate Collins, who was a Gastroenterology advanced trainee at the time of recording, however is now a fully qualified gastroenterologist working at Barwon Health, Geelong. She has 17 publications. Well, yep, that makes me feel a bit lazy, and look, a publication this year even. Anyway, aside from the learning curve for podcasting and interviewing, my conversation with Kate also had a significant impact on my perspectives on patients with liver disease. It's easy to be dismissive or frustrated by repeated admissions of patients with alcoholic liver disease, or even to assume a patient with cirrhosis got it because of alcohol misuse. Kate's perspectives challenges these notions and certainly provides some food for thought. So without much further rambling from me, let's get to it. All right. So thanks for coming. Do you want to tell me a little bit about yourself, about your life, wherever you want to start?
Yeah, sure. I guess maybe age helps to find someone.
Yeah, how old are you? I don't even know how old you are.
So I recently turned 30 and had that, 12 hours of existential crisis thinking you're in your third decade of life and what have you achieved, and then realising.
Happy birthday.
Yeah, thank you. You just need to get over yourself and move on. So I'm a current gastroenterology trainee. So this is my first year on the program. I'm PGY 6 for context within medicine, and I completed undergraduate medicine. I grew up on a dairy farm, so my parents both worked on a farm. I wasn't born there but moved there soon after. And I think that's been a big part of my life, and a big part of my identity was my two parents working and working really hard to try and give us sort of myself and my brothers and sisters everything possibly we can. And I think that'll certainly define my life going forward, being from a regional area. I think it's given me a bit of a unique perspective.
Sorry about the cat.
I currently live in Geelong. My partner or fiance lives in Melbourne, which has been a bit tough for the last sort of 12, 18 months, particularly with COVID and sort of restrictions, but we'll be living together again next year. Which will be good.
Yeah. Where's the farm?
So it's in central Victoria, so about half an hour out of Shepparton. So midway between Shepparton and Echuca, and I went to high school in Shepparton.
Oh, did you?
Yeah.
I think I'm not sure if I knew this or not, but I worked in Shep.
Oh, no, I didn't know that.
Yeah,
no.
I interned in Shepparton.
Oh, okay, yeah.
I was there for a year and a half, so dated a girl from there. So, know some towns around there.
Yeah, it's a bit of a funny place because it's so working class and there's a really high immigrant population there. Funny place, and I think it's been particularly hard hit sort of in recent times with sort of working class access and orchards and things like that.
Yeah. Are your parents still there?
Yeah, they are. So they've been there for about 28 years. So working 7 days a week, 365 days a year for that long is pretty tiring. So they're in their late 50s and looking to, they say retire. I say move to part-time, which is probably full-time hours for some other people. And they're hoping to move to a property outside Whittlesea. Their sort of version of a retirement property is 100 acres, so a little bit unique. Yeah.
I don't know how to gauge that in my head, but that sounds like a lot.
Yeah, it's a big property. Yeah.
How many hectares is that?
I don't know. My parents have always spoken in acres. It's a funny thing in farming. Most people would talk in terms of acreage. Yeah.
There is a conversion, right? I'm not making that up.
There is.
Okay.
There is. It's hard to know what that converts to. Essentially, their dairy farm that they work off and have sort of 100, 150 milking cattle and some calves is 260 acres.
Yeah. This cat is
going to cause some havoc.
Yeah. This is why I don't let her in here. Anyway. So what brought you into medicine?
So through high school, so I entered undergraduate medicine, so I went straight in from high school. I think I almost applied in the end thinking I wasn't going to get in. I think in year 7, I really liked the idea of biology and the concept of the body, and that there was a, psychological aspect to people as well. And I didn't think I'd get in far as scores wise that were required to get into medicine at that time. And even my careers advisor, I'd asked, and he said, I just don't think you're going to get in with that score. He didn't mean it in any negative way, but I thanked him for his honesty. I managed to get an interview on a rural list, so there were some special considerations for people from rural and regional areas, and I just left it at the top of my preference list, and I ended up getting into a rural cohort. So I did my first 2 years at Monash, which is on campus, and then my final 3 years were mainly split regionally. So I spent 12 months in Mildura and then 6 months in Maryborough, which is sort of partway between Bendigo and Ballarat, and there's about 10,000 people there, and a bit of time in Bendigo. And in the middle of that med school duration, I had a year off after second year. I was pretty burnt out, which is strange to believe reflecting on that now, that after med school, compared to the amount of work I do now, that I was burnt out. But I think it was really good for me at the age of 20 to have a year off, and have something to go back to afterwards.
So is that like a bonded?
No, I was unbonded. Funny enough, it was called the Extended Rural Cohort, and a lot of people that I was studying with ended up on bonded programs, which is funny because it would have suited me fine. I'll probably end up serving the time anyway, but I think the evidence shows that putting people on bonded medical scholarships doesn't actually increase their chance of wanting to work regionally. It's actually putting people in programs that are from regional areas who want to go back.
Yeah. So as to getting into it, you said it was the year 7 just biology attraction. Was there anything sort of closer to in year 12 or anything that made you want to pursue it still? Or
I think I had a lot of respect for one of the GPs in the community. So my family grew up playing hockey, and there was a family of a husband and wife who were both doctors. The husband had actually delivered my younger brother, and then the wife was a GP, and she'd known my family throughout, and we grew up with their children as well. And I'd seen her as a patient, I think, once or twice, but she'd spent a bit of time seeing my mum for a short amount of time. And I think for a medical person to get through to my mum was quite significant for me to see as in my teen years, that someone had that ability and that amount of empathy and time. And so I certainly looked up to, her name's Ursula, her then, and I definitely think that had a big influence on what was going on. Yeah. There's no one else medical in my family. Frankly, no one else had actually ever been to university in my extended family. So it was all a bit of a new experience.
How did your family take it when you put it to them?
It's that I wanted to do medicine. They were happy to encourage me. I think I had said to them, look, I'm interested, but if I don't get in, I wasn't going to be bitter about it. I'd seen some other people in years above me be a little bit upset that they hadn't got directly into medicine, and I'd decided even at 17 that I'd just be happy with what I got in with, and if I wanted to do medicine after that, then that's something that I would pursue. But somehow I managed to skip that step. Yeah.
And what were you thinking as backups?
So I'd applied interstate. So my dad actually flew me up to Newcastle for a day to go to an interview. They were quite supportive. But I think I'd said I'd do biomed, which sounds like a very classic answer.
So it wasn't sort of any other career pathways that was just as attractive or appealing to you?
No, not at that time. I think in the back of my mind, I'd wondered whether I'd be a teacher. And I still wonder that now, whether I hadn't done this, whether I'd be a teacher, but it's not something I'd applied for at the time.
Yeah. And how did it progress to where you are now?
So it took me 6 years to finish my med degree, so a year off in the middle and then the 5 years. And then I got an internship in Echuca. So I'd applied there. That's near where my family are. And it was a first year that they'd taken interns. They took 5 of us. Yeah. And it's a GP-run hospital with the main.
I was placed there actually as a student in my last year.
Yeah, it's quite a cute little town, and it's got this interesting vibe because it's such a touristy place. So it was the main attraction at that point was also that they offered a GP rotation, and the government had just cut I think it was PGPPP, or there were GP placements available in internship. So I was interested in that and interested in being somewhere that was a bit smaller and would offer me somewhere that I wasn't kind of going to get lost in the crowd. I didn't spend a lot of time in the major metropolitan hospitals, and when I went there, I frankly felt a bit lost. I didn't know where to go. I didn't know who people were, whereas I'd always been in other small environments. So, for instance, my third year in Mildura, there were only 10 of us for medical school, and so we had a lot of sort of leeway and a lot of flexibility, and people knew us, and I felt quite comfortable. So I ended up in Echuca, and then I realised quite quickly actually that everything I liked about GP I could get within the hospital system, and there were probably some things about GP that I was going to attract that perhaps I wasn't going to be as comfortable with and coping with. Even as an intern, I was getting people that were divulging a lot of mental health things for me, and while I'm happy to listen to that in my job, I just felt I can't do this all day. And I think I also struggled with the idea of sitting in a room for the entire day. I really like the social aspect of being in an acute hospital setting. So then the next step is I've been in Geelong for 5 years now. I was actually unmatched for a job after internship. So I'd applied to some places in Melbourne, and I had interviewed at a couple of them, and I was perhaps a little bit too honest in saying that I didn't know at that point whether I wanted to do GP work or whether I wanted to do a medical year. And I think it probably looked poorly that I'd been at a very, very small hospital that had a new internship program, and so I didn't get a job, which sounds pretty stressful, but it was almost like I knew it before it would happen. And then before the end of the day was out, I'd been offered a job in Geelong, and I've been here and been very happy ever since. Yeah.
Was there a 2-year matching? Was it another PMCV matching, was it, for second year?
Yeah, I'd applied for the medical stream, so it was PMCV based.
Okay. Yeah, I didn't do that, so that's probably why that sounds different to what I went through. I was unmatched for internship, so I can relate to that stress of it. I probably shouldn't have divulged that information. Anyway.
No, I think it's probably good to reflect that, all those years down the track, it hasn't been such a big bump in the road, and that you end up in certain places because certain things happen to you. So I guess one of the things I'm most thankful for, like being in Echuca, that small place, was that I met my partner there.
Right.
He was on rotation. So, I think sometimes good things happen from where you end up, and you just make the most of it.
And even probably clinically, having less support, you'd be expected to step up a bit more than you would probably in a metropolitan region as an intern, at least.
I think when I moved on to residency, I was very much used to being an independent operator, and it had sort of set me up quite well. Yeah.
And how did you get into gastro?
So I finished my physician's training here after, PGY 4. And then I did an unaccredited year. So Geelong had previously, not next year, taken someone to do half gen med, half gastro. And I knew about that because I'd been in Geelong for a while. I did that job and had gastro in the first half of the year, and then I went to Warrnambool, which I'd been at before, for a rotation for the second half of the year, and then I managed to get onto the program. It ends up being quite heavily your CV points sort of get you over the interview line, and then there's some shortlist interviews. It's quite a stressful time. What getting into advanced training is, you sort of feel like you're forever in the hamster wheel, going around trying to build up your CV points and go to interviews and try and prove yourself. You really just want to sometimes shake someone and say, just please give me a job and I'll work hard.
So how does it work with physicians? Because I'm not that familiar. I know that the advanced training, I guess, occurs after you pass your exam, the big exam. Is it just applying to a training position that is an advanced trainee in a specialty area, or? So
you apply, there's a centralised sort of match process now, but there didn't used to be for every specialty. And so for gastro, you normally send out some feeler emails and maybe chat to some consultants beforehand just for a few minutes and meet people. And then it's based on CV points to get shortlisted. And they, for instance, in my year, shortlisted 20 people for what they call these speed dating interviews. And then there were 12 of us that got on between Victoria and Tasmania. So I think there's anywhere between 45 and 60 people that initially apply for those positions. And then there's speed dating's this very intense evening where you have 3 different stations where there's 4 or 5 consultants asking you some questions and you answer. So you feel just very sweaty.
Is that for a specific position or just central?
This is just to get onto the quote it, sort of to put it in quotation marks, the program.
Right.
And then once you're sort of on for the next 2 or 3 years and move around.
Okay. And how do you decide which hospital you'll work at?
So you end up putting preferences and then
Right.
the hospitals preference you, but the truth is most people end up being hired by the hospital that knows them.
Yeah. So that 12 people is for all of Victoria essentially?
So that's Vic and Tas. There's 10 Victorians and 2 Tasmanians. Some of the positions are a little bit flexible and change between first and second year. So I think Tasmania's got second year positions for next year. Yeah.
And apart from passing the BPT exam, what else are generally considered requirements or prerequisites?
So there's no exit exam for physicians, at least for gastro, which is lovely. Sorry to make you a bit envious,
Yeah,
Vish.
thanks.
There's
Although that said, the BPT exam is probably a lot harder in some ways than our primary, so I'll allow it.
the physician's exam, I think the clinical certainly, it definitely makes you a better doctor. I think the written, sometimes I questioned what the purpose of some of these multi-choice questions were, but the clinical definitely makes you a better doctor. There's those, and then there's requirements for the sort of mini CEXs and sort of reviews from your consultants. That's pretty standard, and you would do that through basic physician training anyway. And then there's, for us, scopes requirements. So the sort of minimum 200 colonoscopies, 200 gastroscopies. You wouldn't be confident by just doing that bare minimum. And then for gastro, there's some interventional gastroscopies that we need to tick off as well.
Is that prior to getting onto the training program?
No, that's during the training program.
Yeah. But to get onto the training, what else? Is there prerequisites for that?
No, there's no other prerequisites.
Okay.
It's just finish your physician's training and have enough CV points to get on.
Yeah. And what do they look for on the CV?
So it's research is the main base of where you can get the points. There's previous gastro experience. So me doing 6 months of unaccredited work was beneficial. Then there's other things. I think you get points if you've been a Rhodes Scholar or something fancy like that, or you've been high-level sort of sports achievements, presenting at conferences, teaching things.
And does that have to demonstrate sort of interest in that area, or can it be, if your research or publications, does it have to be specific to the training that you're wanting to get into, or can it be other things as well?
I'm not sure if they directly relate the points if it's related to gastro. I'm sure it certainly helps.
Yeah.
But I don't know whether they make that distinct differentiation.
Yeah. And then it's the interview process, like you mentioned. And
Yeah.
Okay. Why gastro?
It's someone said once to me, you won't your specialty won't necessarily find you, you'll find your people. And I think that's certainly the case. When I started at Geelong, I wasn't really sure what specific physician specialty I was interested in. And at the last minute, sort of midway through the year, I was swapped from a hospital in the home rotation to gastro. Someone called me and said, do you want to do this instead? And I said, yeah, sure. I don't really know anything about it, but that's fine. And the gastro rotation gave me a lot of autonomy. So the registrars would be off at endoscopy and I'd be there in the afternoon. And the patients I really enjoyed, I quite like a chronic liver disease patient. They've all got really interesting stories and personalities of how they've got to the situation they're in. And my team of registrars were really supportive of me. And the consultants were all really lovely. Like I always felt that I learnt from them and I didn't feel intimidated to be in their presence. And I thought at the end of the rotation, sure, that's just something I've enjoyed. It's just the circumstance that I've really enjoyed. I'll, find something that I'm interested in one day. And I went away and ended up doing an oncology rotation, and then I did a neurology rotation. And neuro used to be on the same ward as gastro. And I'd be on the ward round and I just was so much more interested in what the gastro patient next door to my neuro patient was up to, that I think that was the moment in realising that those were the people that I wanted to be with and I wanted to look after. And here I am, and that's where it's ended up. Yeah.
Okay. It's interesting though, I guess you mentioned as an intern in Echuca and dealing with psych issues or emotional distress of patients, and that was difficult for you. Whereas with gastro, with the patients with chronic liver disease, I imagine that there's a lot of psychosocial distressors that or concurrent with their disease presentations. But you seem to like that compared to when you were an intern, I guess.
Yeah, I think perhaps I get to focus on a number of aspects of someone's health at least when they're in hospital or when they're in clinic with chronic liver disease, and their sort of psychological health and psychosocial health is a part of that, but it's not the primary issue of why they're coming to me. So it is interesting that, and perhaps I haven't really thought about that, but you've made me think now.
Excellent. This podcast has a purpose. I won't name names, but I had a coffee meeting with an intensive care consultant once, talking about sort of from a career advice that I asked for, and it left with that person being like, you've made me reconsider my career pathway now. It wasn't my intention. I apologize. I guess I preempted my next question I was going to say anyway. So how do you feel, what do you feel your role is as a physician towards your patient as a gastroenterologist? And how do you think that might be different compared to a different specialty? Yeah. Or even maybe to simplify it to some ways, how do you think it's evolved from you as a junior doctor to where you are now?
So with the inpatients, at least, I'm sure it'll change later with more private outpatient practice. I think there's some patients that we look after and that are very similar to perhaps when I was in Gen Med, where our care is perhaps transient, that I don't necessarily feel like the primary person who cares for this patient. And I don't mean that I'm not providing care to them, but I feel like their general practitioner and their community teams are their primary care person. And there's times in which I'm a transient sort of being in which we help them deal with, one or two issues, see them a little bit. I think for gastro, particularly with the chronic liver disease patients, there are times when that changes to being we are sort of the primary person looking after them. And I've had that experience working here because I've been here for so long now, that there's patients that you see over and over and over again with, trouble, particularly with chronic liver disease and decompensation, where you almost sometimes feel like you are their primary care physician, although it's just when they're in the hospital. So I think it's very different from the Gen Med time that I had where I was doing pure general medicine. I wonder whether some other specialties, sort of subspecialty physicians like neuro and endo might feel like that for their patients as well. But it's become more over time that there's patients that you feel like are almost like your semi-privates, even though I'm a public-based registrar. One of my co-registrars said to me while I was on leave recently, a patient came to the emergency department with my full name written in biro on their hand, asking where I was, because I dealt with them a few times and called them, trying to manage them essentially in an outpatient setting to avoid people coming to hospital that don't need to. Yeah.
Do you do clinics as well, I imagine?
Yeah, we do. Yeah.
And hepatitis, is that ID here or is that gastro?
It's shared. Okay. So viral hepatitis is under the banner of the name Liver Clinic at Geelong. And so it's a combination of hepatitis B and C, and I think we've got one hepatitis D patient. Where ID sort of do the first half of the clinic and then we do the second half. But we often share patients. Perhaps some of the more cirrhotic patients would end up seeing gastro at the second half of it so that we can manage some of their other surveillance programs, but we share.
Do you find a difference between outpatient patients' interactions and inpatient ones in, I guess, sort of in your role as a physician again, even though the outpatient ones, again, you might be seeing over a long-term period? Does that vary as well?
I think so. There's a lot more patients in the outpatient setting that I'll only meet once or twice. Right. I think COVID certainly highlighted how much I relied on how the feeling of a patient being in your presence and you getting some sort of rapport. So in outpatient clinic, when someone's present, it's very different to talking to them on the phone. I've found the phone situation where I've written dictated an entire letter, and then the patient comes back or comes in inpatient setting and someone says, oh, you've met them in clinic, and I can't remember, but I previously seeing them, I would have remembered them because they walked a certain way. They told me about their kids. They had something to do with them.
Yeah.
So I think COVID certainly made the concept of outpatient clinic-based medicine so different from inpatient medicine.
Yeah. And is that just telehealth was in phone calls or not sort of a video conference? Or?
We've only managed phone calls. The outpatient service setting up a video has just been a nightmare.
Yeah, it's been hard enough with our ICU education, so I can imagine with patients as well.
Try doing a 3-way tele call with an interpreter and a non-English speaking patient who hasn't, done their bloods because they don't speak English, they don't know where to go. It's pretty tough for them.
Yeah, outpatients is a bit of an unfamiliar environment to me. I haven't had to do much of that in quite a few years, so I can only imagine. What do you wish from your experience as a gastro, I guess now a senior trainee, that other specialties understood better?
That cirrhotics aren't bad people.
It's their fault.
I think sometimes there really is an unconscious bias that this person has chronic liver disease, therefore they've either injected drugs and given themselves hepatitis, or they're an alcoholic and they're a bad person who's neglected their health. I think that's such a small percentage of the population that we deal with, and I really don't think people are set out to be malicious. But there's certainly that bias. There's many times where I've had a patient who's been really unwell and we've needed support from anaesthetics or intensive care, and the first question I get asked, why have they got liver disease? And I was like, well, they've got cirrhosis and it's because of, for instance, they've got alpha-1 antitrypsin, which is a genetic problem. I was like, this patient doesn't drink or inject drugs. They're just unlucky in this setting, or they're people who have been alcoholics in the past and now they're sober and unfortunately they're dealing with the consequences of their brittle liver disease. So you sometimes feel like you've really got to fight for them, and I have to say sometimes I enjoy that of saying, come on, fight for this patient that I really believe in. Yeah.
Anything else?
I think other specialties perhaps don't realise how much outpatient work we do or how hard we try to keep people in the community. I feel like that's a lot of my day at the end of the day. For instance, last night at 7:30 and I'm calling patients, trying to organise things as an outpatient to keep them from presenting, which is hard calling at that time of day because it's no caller ID from the hospital phone and they all think it's a telemarketer calling them and they answer a bit gingerly. Yeah.
And are these sort of chronic liver patients generally that you're referring to try and...
No, anything. So patients that need investigations for anemia, patients that need endoscopies or follow-up from results that need to be given. Yeah, inflammatory bowel disease patients. Yeah.
What have your experiences with ICU been like?
I think they've changed over the time that I've worked here. I think knowing some people changes how I perceive it, and I think I've learnt more about intensive care over time. There's certainly times where there's been patients that ICU have said no to, which you question and go, no, I really want you to take this patient. I really think we should believe in them. But as time's gone on, I think I've had a better relationship with. There's a good trust in saying, we really want to bat for this patient and these are the limitations that we think. And they say, yep, let's go ahead and we'll help you out. So I think it's been better, but I think that also perhaps reflects that I've become more senior and more comfortable with who we think I should, be cared for by ICU or have ICU interventions. Yeah.
Have you done a rotation ICU at all?
No, I haven't. I've only spent some time in Warrnambool that has like a mini ICU sort of HDU setting with the occasional intubated patient. So I think spending time in Warrnambool and seeing that there's certainly patients that I felt like were in Warrnambool perhaps wouldn't be in an intensive care in a major tertiary hospital. But I certainly appreciated that, look, some peripheral vasopressors for a couple of hours isn't a really large intervention. It buys you a bit of time. So I think it certainly would be good for me to see the other side of the fence. Yeah.
What from your side of it, what sort of patients do you from gastro end up in ICU? I guess from my experience has been the main ones will be GI bleeds, and also liver failure patients that we get you guys involved in.
Yeah, it's primarily GI bleeding. So whether that's sort of probably half cirrhotic patients, half non-cirrhotic patients. It's sometimes we call you guys probably quite late. The patient's already in theatre and they're still tubed, and we finish the case and everyone looks at each other in the room and says, oh, they probably need to stay tubed overnight. We better call ICU. So it often, it's sometimes a little bit later in the piece that you guys are called. Sorry.
No. Is that because it's hard to assess how the gastroscopy might go, or?
Yeah, there's some, if you can control the bleeding and the patient's stable throughout the procedure, that's fine. But occasionally it's a difficult and long procedure, and we think extubating them and then having to re-intubate them at 2 a.m. if something goes wrong is not in everyone's best interest. Yeah.
Is it easier to, do you think with more experience you've been able to get assess earlier on which patients might need to be going straight to ICU or remain intubated?
Yeah, I think so. Yeah. You certainly get a feel of who's unstable. But I think that also comes with you're probably doing the endoscopy sooner if the patient's unstable from a GI bleeding point of view. If they can wait a couple of hours until the morning when there's more staff and everyone's awake, then they're probably not going to need ICU.
Yeah. Unless something goes horribly wrong.
Yeah.
So what are you passionate about in regards to your work life as part of gastro? Are there any specific interests that you have?
I'm struggling to choose a subspecialty actually at this point in time. I really like the chronic liver disease patients. I'd love to do some more IBD. But it's probably the cirrhotics that are my favourite. Once again, because they've got
stories.
They've got great stories, and they've all ended up in their circumstance for very different reasons. And I think it comes back to that idea that other people, and I'm not saying everyone, but there's certainly some cases where there's this unconscious bias that cirrhotics are bad people and they've drunk alcohol because they're bad. But you sit down and talk to them and find out why they did that. And these people have lived amazing lives, or they've had horrible things happen to them that they're willing to share with you and talk about. Yeah.
What do you think are your good qualities as part of your clinical practice?
I think my communication is good.
Sounds like an interview question, doesn't it?
I think that I try and be really kind to everyone. I often repeat sometimes in my head that it actually doesn't cost anything to be nice, and that it makes other people's days better if you're involved. And I think I try and really get interested in each of my patients and know something else about them rather than purely being a bit cold and clinical. I think, those are the main things, and that I think I'm pretty reliable. I think I follow up and I'm pretty reliable.
What do you need to work on?
Letting go and not sitting on my computer doing work at 10 p.m. at night, and then not micromanaging.
Right.
Yeah, I micromanage terribly, and I do it more and more if I get stressed. Yeah.
Right.
Yeah.
To your junior staff?
Yeah, I'll just be like, I'll just do this and I'll take it away. I think I probably don't use my junior staff and some of the nursing staff to distribute jobs as well as I could. Yeah.
Okay. Wouldn't have thought that about you, but okay. I'm going to come back, reorder this a little bit just based on what you've said a couple of times. So having grown up in the country on a farm and what you describe your parents to be like, do you think that has a bit of an influence on your interactions with patients, and particularly, the cirrhotic patients that you're mentioning and the stories and things? I imagine not all doctors would have the same sort of interest in, their patients' lives or stories as much as you seem to. Do you think part of your upbringing has had an impact on that?
Yeah, I think as far as identity element, my parents, are defined largely by what they do as a job. And I think I grew up with that same idea that what you do has a big part defining what you are and who you are. So I think my job has such a big definition of that. And I think I look for that in my patients about what defines them, what's that interesting spark around them. I think I had a previous boyfriend 10 years ago now who with some of his friends, he said to me, "Oh, don't ask them what they do." I was like, "What do you mean?" And he said, "Well, they don't define themselves by their work. They define themselves by, their interest in music or other things. They, pack shelves at Woolies because that pays the bills and gets them to do what they want to do." So I like finding that interest of what defines a person. But yeah, I certainly think what my parents have done and how they grew up and how they raised us certainly influences how I think about my job.
Did that boyfriend's comments have an impact on you, do you think?
I think if I'm mentioning it 10 years later, I think it really did. Yeah.
In regards to sort of looking at people outside of their jobs to find other things that define them or, okay. Interesting.
Like, I don't know if I'm allowed to shoot the question back at you.
No.
Like, do you think your job has a big part in defining who you are?
Absolutely. Yeah.
I think for most people in medicine it does.
Yeah. That's, I guess, what I'm trying to figure out as well by interviewing different trainees from different specialties to see how that impacts them and how they look at this as well. So I'm doing this because it definitely has a huge impact on my life and how I look at life as well. So, yeah, I agree. But I guess I've had interactions with other people like nursing staff, for example, who don't look at their job as what defines them. Some that do, some that don't. But trying to get sort of different insights into that, I guess.
I would struggle to think that my job doesn't define who I am. It often puzzles me a little bit when I find people like that. I think, how is it really liberating? Is it interesting or is it boring? I don't know. Yeah.
I don't know either. That's, stumped me. What are your interests professionally that are outside of your clinical practice?
I really like teaching. So whether that's some of the medical students or some of the more junior doctors, I really enjoy that. It's such a pleasure and a privilege to be able to pass on knowledge to other people, I think. Yeah.
And it comes back to, I guess, you having teaching as your backup career. You get to do that now as well. You get to do both.
Yeah. It probably is all linked. Yeah, now that I think about it. Yeah.
Is there a formal avenue for doing that as part of gastro specialisation, or?
I think it's not directly linked to gastro. There's certainly some of my colleagues have got teaching positions at the university. I've helped out where I can. I did a lecture yesterday on some sort of online platform with the first years. I found it difficult to try and fit it into my schedule, but certainly something that I would like to do more of in the future.
Is it expected as part of training?
I don't think formally, but I almost get the feeling in medicine it is expected that you pass on your knowledge to the generation below you.
Yeah, I meant more from the formal teaching aspect of it. Are you expected to provide tutors for students or residents or anything? Or?
No, we're not.
You've alluded to a few of these things, I guess, before. What are your commitments outside of work that impact, I guess, or on your work or are important to you? Congratulations on the engagement, I guess.
Thank you.
I don't know when it happened. It might be quite
related.
belated.
It's nearly 2 years ago, but COVID provided a little bit of a barrier into signing some paperwork.
Yeah.
So I wish I had more interests outside of my work, if I'm honest. So my partner, Armin, is also a doctor. So sometimes we're a bit like passing ships in the night. But that's okay. We make it work. So there's certainly Armin in my life. And I used to play hockey. I haven't been able to play with my schedule for a little while. That's something I'd love to go back and do in the future. Otherwise, I like being at home and my phone not ringing and sitting on the couch. And I like eating a lot.
How's it been, I guess, your partner being a doctor as well and the distance with him working in Melbourne at the moment and you here, how do you balance that? Because
of the COVID rules, he's technically allowed to come down and visit. So he was sort of coming down once a month and often doing an extra shift at one of the private hospitals here. to sort of make the most of the travel down, so to speak. I think we've coped with it well because we didn't really have any other choice. We try and make time for each other when we're both not working to be together. And I think we both know that this is short term. This isn't forever. This is just part of our training cycle and it's nearly over soon, so, which will be good. Yeah.
You both are nearly done, I guess, as far as your training goes. Is that right?
Yeah. So Armin should be finished at the end of next year, which hopefully will provide us a bit more flexibility as far as shifts. And so he works in ED. So I guess with ED, there's probably less layover from shift to shift, whereas for my work, there's constant layover and things to chase and things for me to think about. Yeah.
And this might be putting part of my sort of insecurities about life onto you, but in the future, consultant jobs and that sort of thing, how do you deal with that in regards to both your relationship, I guess, and job certainties or uncertainties in the future?
So with ED, Armin feels like he's got a lot more flexibility. He can work at multiple places to sort of fill up a full-time job if that's what he wants to work full-time. I think that perhaps we haven't directly spoken about it, but it's going to be pretty dependent on where I end up getting a job and setting up a practice. Yeah.
Okay. And how do you deal with the different specialties? And has that sort of had any impact on your relationship?
It's certainly given me much more of an appreciation for the emergency department. Like, truthfully, they get bullied from 360 degrees. The public are angry that they've been waiting. The inpatient teams are angry because whenever they call, they're being given work. So
How dare they?
You've got to really feel sorry for them. And they send about 2/3 of the patients home. So they do a lot of work. In that same thinking, though, I know what they are capable of and sometimes don't do. So perhaps I've got a little bit more of a higher expectation than some because I have this unique insight into what goes on. But I think we should probably all be a bit nicer to ED.
I think we should all be nicer to each other.
We should, but particularly ED. Like, they always get
agree.
ratted on as like, oh, ED's called me again. They haven't done this, or ED this, ED that. But there's certainly the job that I least envy of them is seeing the unfiltered public. Like, anything can come in, from like a child to some surgical complication, an ENT one. I kind of like that my job's semi-filtered for stuff that I'm used to dealing with. And I've appreciated that more as I've become more senior because your repertoire of what you're comfortable dealing with becomes bigger. And occasionally you get referred something and you're like, I've never heard of this and I don't know what to do with this. So I need to check with someone else because it might not be something I'm meant to be dealing with. Yeah.
Yeah, I remember one of the current ED consultants when she was a registrar mentioning to me about people complaining or harassing about bad referrals. But, you know, in ED, you don't get a referral. You just deal with, like you said, the unfiltered public.
Yeah.
It's a very hard thing to do, and to get from that to a sensible referral can sometimes be difficult, and with time pressure added on. So
yeah, they've got this like arbitrary 4-hour rule, which
Yeah.
I'm not sure came from any particular evidence. With a full emergency department, and particularly in Geelong, a growing community for a relatively small hospital. And I think Geelong's ED's big enough. It's just the flow of inpatients that is the main hurdle.
I'm definitely not a hospital bureaucrat, so this stuff's a bit above me. But yeah, I get the frustrations and difficulties of it. Funnily enough, when I moved to Geelong from Shepparton, I was like, wow, this ED is amazing. Everything's so streamlined. And then you work here and you hear from the other specialty teams and seniors complaining about it. I'm like, oh, really? This seems amazing. I don't understand. So you've already answered the next question that I've got lined up. We've talked about work and what it is in the context of your life. Outside of that, how do you generally classify, or how would you describe your perspective and outlook on life? Very vague, open-ended question.
This
is the one that you struggle
question.
with, isn't it?
Yeah, it's the answer 42. No.
I'll take that.
I think my job defines what I do and a lot of who I am. I think in the future, I'd like it not to. I'd like there to be other things in my life. I just have to figure out when I start introducing those things and what
Now that you're
specifically
30,
those things are.
You've got to ask those questions more, don't you?
Yeah. Yeah, it is, what am I setting myself up for as a junior registrar? Is this going to be the rest of my life? What do I do now to change my practice and how I'm going to have a work-life balance in the future?
What other things would you be thinking of?
A family.
Yeah, the obvious one, isn't it?
Yeah, which is, I guess, a funny thing to talk about. I'm not sure if I'm pretty sure other women would feel the same way. It's a difficult thing to bring up because you don't want to be judged on what your plans are and your sort of dedication to the job and doing something else in your life. Yeah.
Has that been in your mind from as far as training has been throughout?
Absolutely. So there's for my cohort of those 12 people that got on between Victoria and Tasmania, there's 3 of us that are women. It was 50-50 the year before, but there's sort of, only a quarter for my year. And I think that makes a big difference. And I certainly ask in my interviews how many women are in your department, because I think it's a valid point. I think it's really important for myself to see other women in higher roles and how they progress with their career and how they've managed to balance things. Yeah.
How many female consultants are there?
2 out of 9 in Geelong. Yeah.
Is this something you feel that you could talk to them about, or has it been something?
Yeah,
to?
and I have. Yeah, it's been really useful to have them there, and once again, why it's important. Yeah.
Part of the reason I bring this up as well, I think I remember you in the corridor once talking about, I think it might have been this year, talking about universal basic income.
Yeah.
Because of the unemployment issues and people being out of work. Is political stuff of interest to you, or is that sort of something that you dabble in?
No, I don't think so. I think there's certain things I'm interested in, but it's not something that I spend all my time reading on. Perhaps I'm exposed a little bit more because my partner's quite interested in knowing the politics of other countries. And while he's not specifically said that to me, just occasionally in conversation he brings up some sort of political scenario in another country that I had no idea was going on. Yeah.
Okay. How do you think your work as a clinician has influenced your life? Well, I guess we've talked about sort of how it's important for your job and everything and how you enjoy the patient interaction. Has it changed how you look at life?
I think that's hard because this is all I've done ever since I left high school. I wonder whether a postgrad student would answer this differently to an undergrad student. But certainly for my adult life, medicine's defined my adult life. I've either been studying or I've been working. So that's...
I guess I mean more from a dealing with people aspect of it. And like you say, this is kind of what you've grown up when you're developed as an adult doing. The reason I mention is, for example, I did palliative care this year, the first half of this year, which I think has influenced how I look at death, for example.
Yeah.
And also what people would seem to prioritize around the time of dying and family and putting that into a different context. I think working as a registrar in ICU had changed my outlook on death as well in a different aspect, or looking at critical illness in a different way or health in a different way. Do you find that for yourself? Like, I guess, again, dealing with these chronic liver patients and substance issues or alcohol and that sort of thing, does that impact you and sort of how you look at your health as well? And
yeah, I think so. I think you're right. When you realise what's actually important to people isn't necessarily what you propose to someone else is important to them, and certainly something to remember when you're dealing with each patient, to stop and think and say, do I think this person wants this, or did I ask them? Yeah, I think that's certainly influenced as my practice has gone on, and I think I swing quite often between being pro-intervention and anti-intervention. You certainly have these swings of, there was a patient earlier this year that I'd known in the context of a long admission last year with chronic liver disease, and he came in under another team and was profoundly septic, and was requiring just about every intervention besides ECMO that intensive care could put at it. And I remember being so frustrated and thinking, really, do we really think this patient's going to survive this and have a good outcome? Knowing what he was like in the community and the problems that he'd been having and his sort of baseline level of health prior to getting sick. And I remember being so upset about it that I was like, why are we doing this? And that guy lived and he's gone home. Right. And it certainly makes you think. I was like, I thought I developed like a balance between my thinking, and I was like, I was totally wrong. And when they woke him up and asked him about it afterwards and said, if this happens again, what do you want? And what do you think about it? And he's like, yeah, I'd go again.
Yeah, right.
And I was like, really?
How old?
50s. Yeah. I guess I'm not allowed to give away too much information, but he's had a lot of comorbidities and mobility issues, and was going to go home with carers, and yeah.
Yeah, right.
Yeah.
I remember. I think we had the conversation earlier this year about that you would never want to be on ECMO.
Yeah.
And I was like, really though? What if you had the flu and just needed a bit of VV for a couple of weeks? You're like, no. Because I interestingly had this conversation with another ICU registrar a couple of nights ago.
Yeah.
Who also said, I would never want ECMO. I'm like,
yeah.
Really?
It's not the ECMO. It's the small handful of patients. Okay, yes, I'm basing my decision on a small amount of patients who, after they've come off ECMO, have got terrible PTSD. And I think for me, I would not necessarily, there's a certain aspect of fearing physical disability, but for me, I think mental health disability and cognitive disability to me are my top tiers in what I value. Yeah.
I didn't mean this to be a goals of management discussion at all. But
No, I think it's interesting because I think it unveils your own unconscious bias. If that's what I want, is that what someone else wants? Yeah.
I remember, I think a few years ago, back when I was doing ICU, Charlie had this online questionnaire thing, putting random clinical scenarios for you to put yourself in that situation and what your values or what sort of interventions you'd want. And I think that was sort of me having done the validate and getting into ICU and seeing these sick patients, and I was like, don't want anything. And see that this amount of suffering and critical illness and but I guess part of it is skewed by working in intensive care that doesn't do trauma, and you're generally seeing older patients, not young trauma patients, which probably to some degree would be just as traumatizing seeing them die or suffer, but also potentially seeing them recover to a good level of outcome as well. But anyway, that's just rambling now. What does the future hold for you?
More training. So I'm finally moving away from Geelong after 5 years. I'm going to the Western next year. Someone pointed out to me who was new to Geelong this year, she said, when I moved, I realised I had to make friends in the hospital. And I had sort of reflected, it's really easy for me to get stuff done now because I've got just about everyone's mobile number. Yeah. You know people. When people ask you of stuff or you ask them, there's this respected relationship that what you're asking for is reasonable and we'll get it done. And I'm going to have to start again, which is a bit scary, but also I think exciting. I think certainly the other week when the registrar said a patient had come in with my name written in biro on their hand and another patient that only the other week the ED consultant called me after hours and said this patient's in ED and he's just asked if you're back from holidays yet. I thought, it's probably time for me to move on for at least a short amount of time. I've had them see me in the street on Packington Street in Geelong and yell across the street from me as they're having Kate, how you going? Oh, okay, yeah. And I'm happy to say hi to them, but there is something nice about not having that identity when I'm at the greengrocer. Yeah.
Outside of work, is there anything you're looking forward to? COVID being over?
I'm really looking forward to living with my partner again. I think the thing I miss the most is that just downtime of physically being in each other's presence. I think you soon realise that that's a really enjoyable part about being together. And I think I didn't perhaps realise the main difficulty I think about living apart is that when we're together, you almost feel like you have to be sort of on and present because this is your limited time together, when the truth is the time we're together that I enjoy the most is when you're not necessarily making a specific effort to do something or go somewhere. It's actually just being together. Yeah.
Excellent. That's very exciting to look forward to.
Yeah.
Well, thank you, Kate, for doing this. Is there anything else you would like to bring up or discuss that we haven't covered? You can say no.
No, I can't think of anything. I'm sure I'll think of something as soon as I've left the room.
You sound like patience.
I'll write them down.
Yeah. Oh, by the way, thanks, Kate. It's been lovely talking to you. Thanks for taking the time to do this. I really appreciate it.
That's
and I've learned a little bit more about you.
Thanks for listening to me ramble.
Likewise. Thanks, Kate.